Welcome to the new Ortho Info podcast, a monthly series where board-certified orthopedic surgeons provide in-depth answers to frequently asked questions about bone and joint conditions, treatments, injury prevention, and more.
So, Kamran, welcome to the Ortho Info podcast.
Oh, thanks for having me.
Before we dive in, I have to ask, what drew you to foot and ankle surgery? My own path started with sports injuries as a college basketball and track athlete, but what made you look at the foot and ankle and say, yes, I have a passion about feet?
I loved ankles. If there was only an ankle fellowship, I would have done that. But the foot got smuggled in there with it as well. I think early on in residency, there was something that I gravitated to about fixing ankle fractures. It was like my favorite thing. I loved them so much. And so I wish it was like a more complicated answer about having an ankle injury or being inspired by how quickly people get better and that they can run and they can do all these things afterwards. It really was just like, I thought this is fun.
Well, I got to do what you love. And one thing I've realized is once you go into foot and ankle, you realize that not many people appreciate their feet until something actually hurts and they realize that they need them to walk. So although ankle injuries are common and definitely in our wheelhouse, this episode is more about why do our feet hurt? What is the cause of foot pain? So a lot of things, as we know, can go wrong with our feet. So what are some of the most common conditions or injuries in your practice?
As far as common conditions, I think probably both of us see a lot of heel pain.
Yes.
And the heel pain comes in lots of different forms. There's plantar fasciitis, which is on the bottom of the foot and has the standard presentation of pain in the morning when you get up out of bed. Then it feels a little bit better, but might throb a little bit if you stand on it all day. And then there's pain in the back of the ankle or the back of the heel that is Achilles type pain, and that can come in various flavors. So I think that's one of the most common things. And thankfully for most people, they don't usually need surgeries for that as well. I think those are some of the most common things. Some of the really exciting things that we see are trauma, unfortunately for us, but unfortunately for the patient. But I really love trauma in the foot and the ankle because it is something where we usually have pretty good solutions generally. And it's one of these things where you get to be with that person on what's maybe the worst day of their life up to that point in time. And then you get to watch them at some point in time, like walk out of your life with hopefully a smile or at least a smirk on their face.
Love a good smirk. Well, I love that you touched a bit on some overuse injuries, which we see, Achilles tendonitis or some of those, which you had talked about the back of the ankle, that big tendon there just from wear and tear over time. You also talked about trauma injuries, which these seem very obvious to some patients where you fall, you have an injury or an accident, and then you know that there's something wrong. You can't walk on your foot. But can you define also some of the injuries maybe that aren't as common, like congenital related deformities or degenerative conditions? What are some of the presentations of these that people should be on the lookout for?
Sure. One of the really gratifying things about practice, I think, is meeting people who have been told that they have a condition that there is no solution for, who have gone years or decades without seeking any additional options. And then they find out from you that there may be something that can actually be done about it. There's a lot of patients that might have congenital issues, like they have a club foot or their foot position is unique and it's something that is causing them pain and they're told never have surgery for this. And it might be something where maybe they don't need surgery, maybe they need the right type of insert or ankle brace, but it might be something where they could actually have a very successful outcome from a reconstruction to get their foot in a better position. I would say one of these things that often gets missed is foot drop. People who just all of a sudden for whatever reason their foot can't come up anymore and they still have good strength in the other parts of their foot but they can't get the foot up anymore and they end up running into issues where they're dragging their foot on the ground or they trip a lot. And this is something where we might actually have multiple types of things that could treat this. One is simply a brace that can hold this up, but the second is if we're able to identify what is the cause of this. Is there a cyst around your knee that's pushing on a nerve or something else around your knee that's pushing on a nerve? Or is this something that is more systemic? But there may be other options for that. And there might be things where, if this is post traumatic, that we might even be able to transfer some tendons over and say, like, hey, don't worry, your friend is here to help you out. And it can pull the foot up as well. So I think those are some of the really interesting and exciting things in foot and ankle.
Yeah, I think you bring up a good point too, talking about all these different things that there's so many things that can go wrong with our feet. I mean, there's ligaments and tendons and joints and the foot is a very complex structure. And there are a lot of times where maybe some people come in and they don't think that there's an answer, but a lot of the times if you really talk through the history and do a real clinical exam and you can really bond with the patient, there are some options, both non-surgical and surgical, that can be offered. So, are there any issues that you are seeing more frequently today than maybe a decade ago? And if so, what do you think is the reason for this?
So I'll tell you one thing that I'm actually seeing less than I was seeing a decade ago. Certain types of Achilles tendonitis or tendinopathy, like one called mid-substance Achilles tendinopathy. So this is the type of Achilles tendonitis where your Achilles tendon in the back of the ankle gets inflamed or irritated a few centimeters above where it latches onto the heel bone. And I think that we just have really good physical therapy for this now and other modalities that are non-operative that work really well. And so, like nitroglycerin patches, which restore blood flow to the area, amongst a few other things that therapists can do, like dry needling. And so, I would say this is one thing where certainly from 10 years ago when we used to operate on it, I wouldn't say routinely, but not infrequently, to now it's something we're almost always able to get people better without having to do a surgery for it. As far as things that I see more of, this is like a little bit of a mixed bag because some of it is just the maturation of my practice. It's like I really enjoy seeing like complex reconstructions and doing some sports stuff. And so that gravitates to me a little bit. I do a little bit less of forefoot surgeries. So like bunions and hammer toes, I oftentimes will pass along to one of my partners who's really excellent at doing those and enjoys them maybe a little bit more than I do. And so some of this is maturation. But as far as epidemiologically, do I think that the disease patterns have changed? I don't know. I think we do see a lot of adolescent ankle injuries now, and so I don't know. Some of that may just be because, like in the sports literature, and the elbow and the knee, it's like the kids aren't getting quite as much of a break from sports, and they're playing year round. Is that maybe they're just naturally injuring themselves, even at the same rate, but they're always playing, and so they're always getting hurt. But I would say maybe that might be one thing where I've seen a slight uptick in pediatric or adolescent ankle injuries over the years.
Yeah, I think you bring up several good points. And I like the fact when you were talking about your Achilles injuries about other treatment modalities and how not even just within orthopedics we've come such a long ways, but even in these non-operative modalities such as you mentioned dry needling, different types of physical therapy. I mean, we have things like shockwave as well, and even biologics like PRP. There's a lot of different things that maybe aren't necessarily surgical, and we have more of these options to try to prevent the progression of the disease and then also maybe prevent the need for surgery. And I also agree with our society that's changing. Younger people are getting more involved in sports and year-round athletics. We also see that there's been an increase in women doing a lot more different types of sports that they didn't do maybe 20 years ago, so they're having different injury patterns, and it's just interesting. So I think that just brings us to the next question, which is, what are some factors that you think maybe contribute to injuries? For instance, maybe repetitive stress on the body, improper athletic shoes, maybe a lack of conditioning. Can you focus on some of these things that maybe might prone us to injuries?
Sure. I would say for people that come in with just their feet hurting, like most everything on their x-rays or imaging looks relatively good and it's just their feet hurt, like a really easy way to get started on that is supportive shoes. And what is a supportive shoe is, beauty is in the eye of the beholder. But I would say just in general, if you take a shoe and you're able to easily bend it, then maybe that's not enough support for you. And it might be something that needs to be not quite a brick, but it's a little bit harder to bend. And that might be supportive. And what is interesting is 10 years ago, I had never even heard of Hoka shoes. And now it's like half of everybody has them in clinic because it's becoming more and more common knowledge that they are good for long distance runners, but they're also really good if your feet are hurting to make them feel better. And I would say that there was probably this window in time where for a few years those may have been some of the best shoes to wear, but I feel like almost every brand has their equivalent supportive shoe now to the Hoka, and so there's a lot of options there. I would say a second thing, especially being somebody who has lived and worked in downtown Chicago, is like every year right before the marathon, we get a bunch of people that pour in that have, thankfully, usually non-operative conditions, but almost always these are things where they have put a little bit more stress on their lower body than the body can handle at that point in time. And so we can call these like stress fractures or stress reactions or overuse injuries if they happen in things that are oftentimes not bones, like tendons and ligaments. And I would say the best way to try to avoid these is have some sort of reasonable schedule. One of the nice things about AI now is you can have something curated for yourself as to how to ramp up and try to stick to it. And so if you haven't run in 10 years, that is perfectly fine. You don't need to make up for it all at one time. And so you may need 6 months to get to the place that you need to be. And that's okay, because in 6 months you'll be there and you'll be happy that you got there after 6 months rather than 1 week in getting a stress fracture and having to be in a boot and deal with that for months. And the last thing that actually goes along with people that like to run long distances and marathons is actually, for maybe all of us except for you, is we're carrying around a couple more pounds than we were before the pandemic. Is that losing a little bit of weight can also help take a little bit of stress off of the foot. And so one of the things that is quoted is that if you take a pound of weight off of your trunk, that may remove about 5 pounds of force when you're running on your foot. And so if you end up taking, a few pounds off, I tell a patient that's like handing off a 15 or 20 pound dumbbell to somebody when you're running, at least. And so anyway, those are some, I think, low hanging fruit, easy things people can do to try to avoid some of those very common foot pains.
Yeah, and I think you're touching on some great points as far as there's not really one size fits all. You described a couple different types of shoes, brands, couple different ways to start increasing your intensity and duration of activities as you're starting to get into sports or maybe trying different sports and really doing that in a stepwise fashion, focusing on not just the foot either, focusing on whole body mechanics, whole body just training, also even thinking nutritionally and knowing that there's not one size fits all. And I know sometimes when my patients come in and they're like, Dr. G, what's the best shoe for me? And depending on what they need, obviously, I'll quote some things about the rocker bottom versus rigid versus, different types of shoe support. But at the end of the day, what works for you or myself or someone else may not work for that other person that needs this. And so it's so nice to see how much attention has been now focusing on variability in this shoe wear that we're seeing in all the different companies. And so that's something that, going to a sneaker store, even though I know we order so much online now and I have a habit of that, it's nice to actually go to these stores though and really try the sneaker out, looking for certain things that you might require and seeing what is the most comfortable thing for you. So, okay, so let's move on to our next topic of when we want to seek help if we're having foot pain. A lot of people like to ignore their foot pain. A lot of us are tough and we don't want to go to the doctor and we think we can walk it off, especially as we're athletes. We don't want someone to tell us we can't run. But what are some symptoms that maybe people should be a little bit more cognizant of, maybe what they shouldn't be brushing off?
Sure. I would say one is burning pain. So if you're starting to feel burning in your feet, like once in a while is okay, or if you had a long day or whatever, that's okay. But if this is something that is consistent and is interfering with your happiness, then you need to go see someone. And that might be your primary care doctor potentially, just to get started, because sometimes people might have neuropathy and they feel like a little bit of burning in their feet. And that might be something that a simple medication or some lifestyle changes might be able to address. But there's really not any harm in seeing a orthopedic surgeon if you have some burning pain in your feet. I would say also, if you have pain that is so bad that it's keeping you up at nighttime, then that is also something that you should seek some help for. It's like life is a grind, but it doesn't always have to be a grind. You should at least be able to sleep. So if you're not able to sleep, that's probably a sign that you need to go see somebody. And then I would say the third thing is, if you go see someone and just something doesn't feel right, like you just don't have confidence in what you have been told, or if something doesn't jive or make sense to you, then maybe it might be worth getting an extra set of eyes on it. And that second person might agree exactly with what the first person said, but perhaps they're a better fit for you. Maybe their communication style matches up more with you. And so that would be the third thing, I think, is if something just seems off, if your spidey sense is going off, maybe go see somebody.
I love a good spidey sense. Are there any red flags that maybe should be treated as medical emergencies? Anything in particular that you're thinking, oh my goodness, they need to go to the hospital right away, be looked at in the emergency room? What are some of those things to be looking for?
I would say I have relatively low threshold for if you have trauma. So
Mhm.
if you fall, you get hurt, and it's hurting really bad, maybe just go see somebody at that point.
Yeah.
I understand that if you try to minimize your symptoms and just say, I'll walk this off, you might be able to, but unless you're 12 years old, it becomes a lot harder to walk these things off.
Yeah.
And it might be good to just go get some x-rays. And if nothing else, you can at least get some peace of mind at that point in time and move on.
Yeah, that's great. What about any concerns for someone who might have all of a sudden red hot swollen joint? Maybe there's concern for infection. Is this something that they should maybe see physician right away for? Is that another thing you're concerned about?
Yeah, absolutely. Especially if you're having a hard time moving that joint. So if it's around your ankle or your knee, then probably need to see someone sooner than later. The toes end up becoming a little bit of a different beast because it's like sometimes people get gout in their toe and it is maybe not as devastating a thing. It looks a lot like an infection, but I would say if you have diabetes or any other issues and your toe becomes red, you should probably treat that like your knee turning red and hot and painful and just go see somebody sooner than later.
And so I guess we've settled that maybe not walking it off is a good idea for everything.
Yes.
Have to tough it
Walking
out.
off does not really work for infections as much as antibiotics do.
Yeah, exactly. So, now our society and our people in general are now turning to the internet more and more as a source of information and resources. And now that we have a bunch of different AI platforms like ChatGPT, which I nicknamed Chatty, in case we have to ask questions, we're seeing that more and more patients are asking a lot more questions from the internet. When is the time to maybe stop Googling and actually see a doctor? Any advice on patients who are looking at the internet and how they should approach internet responses before seeing a physician?
Yeah. This is a tough one because some of the AI foundational models like ChatGPT or Claude, they actually have a lot of really good information and that can be helpful right then and there. The downside is that sometimes the information is not nuanced enough for the patient. Sometimes the information does not actually apply to that patient. And sometimes they hallucinate and they literally will give you nonsensical information that sounds very confident. And so I think it is okay to try those things, especially to answer some simple questions, or maybe even get a little bit more information. But you should get that information from AI with a healthy dose of suspicion, in that perhaps try to validate the information that you get by looking at other resources like primary resources on Google or even another AI bot to see if they agree with it as well. And then I would say the same thing going back to the spidey sense is if it is still not adding up, go see a reputable doctor.
Great advice. Speaking of seeing doctors, when do you think a patient should first maybe go to a primary care specialist versus an orthopedic specialist?
Mm, Well, one is some people have limitations based on the type of insurance they have where they don't really have a choice. And then the second is this is like a challenging area of matching the right patient to the right doctor at the right time. And it's very tough. This is a tough one to answer. And one thing that the patient can do is if they think that they might need to go see an orthopedist, is they can even call the office beforehand and just say, hey, this is kind of what's bothering me. Is this the right person to see? And they might be able to give them a little bit of direction. I would say that a place that is a very cohesive unit where either the schedulers work closely with the physicians, as in some practices, especially private practices, then they might be able to give a little bit more nuanced answer than a very large conglomerate where there are dynamic schedulers that are scheduling for everyone in all 50 states. That person may not really have much of an idea as to who sees what. And so this is a challenge, but one that I'm hoping that companies and AI will be able to solve for us is how to match the right patient to the right doctor at the right time.
Yeah, I think too, it seems like access to some of the urgent care clinics and maybe a primary care physician might be a little easier than figuring out what subspecialist to see when it comes to orthopedics. So I think probably can see one of the urgent clinics first or the primary care physicians,
Right.
especially if you're able to walk or if it's more chronic in nature. And then they can always refer you and give you some recommendations based on what they think. There's no problem going through that channel. And I think a lot of patients, they see the term surgeon and think, oh, it is only surgery. That's the only thing that those doctors do, but that's not necessarily true, where we do actually try to treat our patients conservatively first. And then only when you absolutely need surgery is that when it's usually indicated. And I think knowing that you can see a surgeon, even if you don't think you might need surgery, but also going through the other channels will help you get more information. I call it data collect about your injury and then figure out what the right fit is for you. And so, along the same lines, as far as trying to figure out pathways, there are listeners who have either seen a foot and ankle orthopedic specialist versus a podiatrist. And we have a great relationship with our podiatry colleagues. There's a lot of overlap in what we do, as well as differences in what we do. Can you give us just maybe a very brief summary on maybe the difference in training and the way we are brought up into our pathways? And then we can talk a little bit on how you can determine seeing what specialist.
Sure. In the Venn diagram of what we take care of as orthopedic surgeons that specialize in foot and ankle and what podiatrists take care of, there's like a lot of overlap. There's a lot of stuff that we can both see. I think orthopedic surgeons go to a traditional medical schools, allopathic or osteopathic. There is a 5-year residency in the United States afterwards, followed by a 1-year foot and ankle fellowship. And at the end of this, I would say that most of us spend our time taking care of bones and muscles and tendons and ligaments and like the major structures. We usually don't veer too much into like foot care or nail care. And so there may be a little bit of a divergence there in that I would say foot care and nail care and diabetic foot care is not really part of my practice, at least. It might be for some other orthopedic surgeons. Conversely, there are podiatrists, depending on which state they're in and what their comfort level is, who manage trauma and do other things, and they might not only adhere to some of the things that we classically think of for podiatrists. And so it is very much a gray area. I think that the choice on whether to see an orthopedic foot and ankle surgeon or podiatrist, it really depends on a couple of things. The first is availability. And so if you live in a place that doesn't have an orthopedic surgeon with the foot and ankle specialty, then you maybe don't have a choice there. And there might be podiatrists who hopefully are able to do some of the same things. And so that might spare you from a decision. But I think most people live in a place that may have coverage from both. And then you need to do some reading and learn about the specialist and who matches your needs the best. And again, I'm hoping that coming down the pipeline will be some healthcare AI that is able to match the right patient to the right doctor at the right time.
Yeah, I think that's great and a nice overview. And I think at the end of the day, patients, especially now that we have AI and social media and the internet, and they are finding their more autonomy in the decision of who they're going to, where to go, and also trying to connect with the physician. So my advice to a lot of my patients is, research, do your due diligence just like you would for anything that you're going to, whether it's investing your money or going for your car or whatever that looks like. Once again, we're in the phase of data collection. Figure out what the background is, see what kind of injury you have, and then maybe get second opinions from different types of physicians as well to see what's a good fit for you. And then you usually will end up in the right place. And so now, as we get to scheduling, when a patient does have an initial visit and they have an appointment scheduled, is there anything in particular that patients can do to prepare for the visit? What usually happens during that first appointment with an orthopedic foot and ankle surgeon?
Yeah. I would say come prepared to talk about what is bothering you and have an honest discussion about that. I think sometimes I will have patients that come and we talk about some things that are going on, but like the actual fear that they have and why they're there may not present itself early on. And so remember that your discussion with your doctor is protected information and there's HIPAA and that you should just let them know what is really on your mind and what's bothering you. The second thing is, if you can find a way to be able to point with one finger to one place, what is bothering you the most, that's a helpful place for us to start. Because if we can have some sort of geographic landmark, we know which structures are in that area. And if you point to your entire foot, it's okay if that's all you can do. But if you can really think about before you come in what's bothering you the most and how to describe that pain to someone. If you could find out how to describe that pain to someone who can't see very well, that's a good way to get started. And then the last thing I would say is write down either on a piece of paper or on your phone the questions that you have, because that is the best way to make sure you ask the questions that you want to ask. And I would say most of us are very happy to answer all the questions, and we want you to be satisfied with your visit and get what you want out of it before you go home, rather than driving home and then thinking, oh gosh, I wish I had asked this.
Yeah, this is a great advice for this. And I love I do the same exact thing when I have a patient come in. I'm always like, okay, if you can point with one finger where it hurts you the most, and then depending on the patient, I'll say, okay, maybe I'll give you two places, but I want an order of which one's worse. And another thing I also will ask patients is, if there's one thing that I can change about this foot and ankle of yours, one thing that would make you be able to do the things you want to do, have a great quality of life, what is that one thing? Is it pain? Is it instability? Is it the pressure of the bunion on the shoe? Like, what is it? And I think that is something where that's also connecting with your physician and finding the physician that you are comfortable talking to. Like you had said, it's important to be honest and open, and being able to express that, have that rapport where you feel comfortable speaking about what's really hurting you, and then really digging into what the underlying cause is. And I think if you have a good relationship with patients, you actually can get so much more information to treat them better. And as far as also, dealing with patients and their expectations, sometimes foot and ankle surgery is hard. You have to be walking on this foot, whether you are being treated conservatively, whether you're getting a surgery done. I always joke with our hand colleagues, they can just hang out there and their arms waving. We actually have to put weight through this. So you always know that you had surgery. What are some of your methods of setting expectations about recovery, return to activity, long-term function? How do you have that conversation with your patients?
Yeah. I think try to eliminate the unknown. And so there's some things we can't know, but at least we don't need to be surprised by the stuff that we can predict. And so some of the important things are framing what realistic recovery might look like. And as far as one size doesn't fit all, this is like another place where you can't just say it takes 6 months to recover from this, or a year to recover from this, or 3 weeks to recover from this, because what recovery means to one person doesn't mean the same thing to someone else. To one person, just being able to walk without pain and a limp, that may be a win. For somebody else, it might need to be dunking a basketball. And so these are like two very different outcomes. And so I think laying the groundwork, oftentimes it's probably helpful for the physician to not necessarily give like a defined time point. This is going to be 5 months and 30 days. This is going to feel better, but rather like reasonable ranges where the majority of people fall into it. 4 to 6 months, people are doing pretty well and are happy that they did this. And so I think that's helpful. On the front end of the recovery, though, I think it is okay to just give a little bit more concise idea of how long you won't be putting weight on there. It's one thing that I have learned over time that has given me some gray hair is knowing beforehand whether somebody will be able to use a walker or crutches, because if not, they're going to have a real challenging time. Another question that is good for the patient to think about before they talk to the doctor, and for the doctor to think about before they sign someone up for surgery, is after surgery, will you be able to get yourself into the house, and will you be able to live in your house without being able to use one leg? So in somebody that for whatever reason is not really going to be able to use crutches or a walker or a knee scooter, what have you, it's like even a few steps to get into the house could be a major challenge after surgery. And then if you go into the house and some of the vital rooms are like the kitchen and the bathroom are on two different floors, this can make things really challenging. And so these are questions to ask before surgery. Along with that, in the same vein, is somebody going to be helping you out? You live by yourself. Foot and ankle surgery will really test your faith, I think. And if you have somebody or a whole family that can help you out, then maybe it's not going to be so bad. So these are important questions to talk about and discuss before surgery, especially because I would say the majority of foot and ankle surgery is probably outpatient these days, meaning that somebody comes in for surgery and then leaves the same day. And so it's important to have this stuff because it's really hard to set it up right after somebody's in the recovery room.
Yeah, that's great points, because I think sometimes we, while we're so focused on the treatments, whether it's non-surgical or surgical, the recovery is not just the physical therapy and the casting or the splinting. It's the whole recovery of getting home and being able to elevate and getting around and still living a life. And those are all things that really need to be hashed out before, so that the patient doesn't have to stress about this while they're in recovery mode and not able to walk. And I know, we talked a lot about various different injuries. I think we've also honed in on not everything needs surgery, and we always try conservative first. I think one of the things that I've noticed too, both in conservative treatments as well as surgical, is that there's been a lot of evolution in very exciting advancements in surgery and the type of foot and ankle surgery we're doing. What are some things that you're most excited about, or maybe some things you've seen evolve over the last, several years or so that have really helped your patients have better outcomes?
I would say the thing that's top of mind is probably minimally invasive surgery. So I know you're like an expert in that, but that has very much changed a lot from the 10 years since I finished my training. And 10 years ago, they were on the precipice, I think, of having commercially available burrs and little things where you can make tiny poke holes into entire surgeries. In the United States, they'd had that in Europe for a while already, I think, and in Asia, but it was going to be commercially available. And then there were some of us who were early adopters, and I think I got a little, I don't want to say spooked by it, but it was just very hard. It turns out there's a very steep learning curve. And so then I drifted away for a while, and then I've come back again, as everybody else has as well. So I think that is something that with a skilled surgeon that has gotten past the learning curve on it has dramatically changed the shape of foot and ankle surgery.
Yeah, I couldn't agree more. I love seeing the evolution of some of the procedures we did or back in training that were wide open, and now we're doing something very similar through, like you said, the little keyhole incisions. One of the things I also really enjoy is the nanoscope and the needle scopes that we have. They're really small instruments and cameras, and we're doing things in more wide awake settings, whether it's with the camera or with the burr. And that really helps reduce patient adverse events from the OR or anesthesia. And I think our goal is to be able to safely but efficiently, get patients back and get them on their feet moving quicker so that they can resume their activities. Another thing I think that's been really exciting is, even though we've had this for a long time, is the evolution of biologics and regenerative medicine. There's still a lot we need to learn and a lot of studies, but I think the field as a whole is just looking for ways to try to prevent surgery. And if we need to do surgery, do it in a way that can either enhance the repair or do it in a way that can expedite recovery, which is really exciting. As far as recovery goes, I know we're almost near the end. Do you have any important tips when it comes to physical therapy and the importance of physical therapy, as well as maybe even before physical therapy, prehab, and doing PT before injuries in order to prevent further injuries?
You probably know more about prehab than I do. I think it's really nice. I enjoy when people have done therapy before, because this one of the best predictors of how you'll do after surgery is how you're doing before. So if you're strong before, then you'll probably be a little bit stronger afterwards. But I would say that in general, physical therapy is a really great thing. And as coming from somebody who themselves is only partially compliant with PT, even some PT is better than no PT. And I would say that that's probably something that should also be part of the shared decision making and informed consent process, is like, is there going to be physical therapy involved, and just an expectation of whether that'll be done or not. It is, I'll say, as I've gotten further along, I used to have some physical therapists around my practice that I would preferentially send patients to, but as I have different sites that I work at, and there are a lot of new opportunities, and some patients don't live near me, so I don't know any therapists over there. I have found that one of the best pieces of advice I can give to patients is that you should really like your therapist and feel like you're getting benefit from them. And if you're not jiving with them, it doesn't mean that they're not a good therapist. They just might not be the one for you. And you need to let me know, and I'll write you another prescription, and you can go find somebody else that maybe matches up with you better.
Yeah, I think the physical therapists play such a role in foot and ankle surgery for strengthening and, for stability of the ankle itself and the foot, as well as soft tissue work. I even say sometimes that I recommend even soft tissue massages to go to, where they focus on lower extremity work. I think hands-on work really can go a long ways. And one thing I really appreciate with some of the therapists we work with is direct communication with my patients, having that ability to, in real time, have the therapist share their feedback after a surgery or even before surgery or during conservative management. So they really play a big role in the care of the patient. So on that note, it is time to wrap things up. Kamran, we really appreciate you coming today, joining me to share all of your...
Wait, so you asked all the questions. I didn't get to ask any questions. I'm just kidding.
Putting you on the hot seat here.
Yeah, I'm just kidding.
But no, thank you so much for joining us. It's been great having you, and hopefully we can do this again. And
Sure.
Any final words, any final advice for the audience?
Don't worry, be happy.
Don't worry. Keep your feet happy. So
Yes,
I'm Dr. Ariana Janakis, and you've been listening to the new Ortho Info podcast, where we answer your questions about musculoskeletal conditions and care. I hope you enjoyed the conversation and will listen to future episodes. Take care of your feet. They are the only pair you get.
This has been the Ortho Info Podcast, brought to you by the American Academy of Orthopedic Surgeons. Production and editing by MK Quinn Media. You can find the Ortho Info Podcast on orthoinfo.org and wherever you get your podcasts. Like and subscribe so you won't miss new episodes, and visit the Ortho Info YouTube channel for full video podcast episodes and shorts. The views and opinions expressed by guests are their own, and their appearance on the podcast does not imply an endorsement of them or any entity they represent by the AAOS. Reference to any specific product, device, or service during this podcast is for educational purposes only and does not constitute endorsement or recommendation by the AAOS. Ortho Info, expert musculoskeletal health information provided by surgeons, trusted by patients.